Good morning, everyone. My name is Anil Kumar. Topic for today's seminar is etiopathogenesis and management of anaphylaxis and anaphylactoid reaction. Definition is anaphylaxis reaction is a potentially life-threatening systemic allergic reaction involving one or more organ systems that typically occurs within seconds to minutes after exposure to a anaphylactic trigger, most commonly due to some drugs or foods or bee stings. Anaphylactoid reactions are non-IgE-mediated reaction to certain drugs, which can mimic pathophysiology of IgE-mediated anaphylaxis due to similar profile of mediators. Immediate reactions depends upon the release of mediators of inflammation by tissue mast cells or circulating basophils. These mediators includes histamine, leukotrienes, prostaglandins, bradykinins, platelet activating factors, enzymes, and proteoglycans. The main difference between anaphylaxis and anaphylactoid reaction is anaphylaxis is IgE mediated and anaphylactoid is non-immune reaction which directly stimulates mast cells or basophils. Coming to the pathophysiology, in anaphylaxis, when a person is exposed to an allergen, it stimulates B cells. B cells in turn stimulates plasma cells. Plasma cells produces IgE. IgE during sensitization, those settles on the mast cells. When a person is re-exposed to the same allergen, that is shocking dose, in such a time, degranulation of the mast cells and the basophils occurs, mainly due to preformed IgE on the mast cells and antigen complex reaction. Mast cells and basophils contains preformed granules comprises of histamine, proteases, proteoglycans, TNF alpha, which are released into the surrounding tissue upon the cell activation process known as degranulation. Mast cells, basophils, and eosinophils are also the sources of arachidonic acid. We also know that arachidonic acid itself is a source for prostaglandins and leukotrienes. Histamine thus released due to degranulation causes flushing, urticaria, pruritus, and in higher concentration, hypotension and tachycardia. We all know that histamine receptors for histamine are usually located in the H1 are usually located in the blood vessels, H2 are usually located in the GIT, and H3 usually in the CNS, central nervous system. Whenever there is a release of histamine due to H1 receptors, there occurs flushing, urticaria, pruritus, and due to H2 there will be gastrointestinal symptoms, and due to H3 there will be altered sensorium can also occur, which is very rare. Due to vasodilatation due to H1 there will be hypotension and reflex tachycardia. Histamine, leukotrienes, and prostaglandin D2 causes bronchoconstriction and increases microvascular permeability. In comparison to histamine, they also causes microvascular permeability, but to a less extent. Their main action is bronchoconstriction. Prostaglandin D2 causes cutaneous flushing and attracts eosinophils and basophils to the site of mast cell activation. Serum platelet activating factors levels correlates with anaphylaxis, because whenever there is anaphylaxis, there is degranulation of mast cells and there will be a release of PAF. If the PAF levels are high, it directly correlates to the severity of the anaphylaxis. PAF is inactivated by PAF acetyl hydrolase. So whenever acetyl hydrolase levels are high, PAF activation will be low and anaphylaxis will be low. So there is inversely proportional inverse relation between PAF acetyl hydrolase and severity of anaphylaxis. Tryptase and chymase, these two are very important, because until now the mediators we are discussed, they are of short life, they have very short life, but tryptase and Chimeras have around 1 day, 2 days. We can half life, so that they are helpful in diagnosis of anaphylaxis. Active, tryptase and chymase causes activation of complement and coagulation pathways, which results in production of anaphylactotoxins like C3A and C5A, and activation of kallikrein and kinin systems, which regulates blood pressure and vascular permeability. Anaphylaxis. Coming to the etiology, it is more common in adults due to some foods or exercises or latex or idiopathic, mostly due to parenteral exposure. Most common in males in comparison to females. In males due to some exposure to bee stings, hymenoptera, matlab bees. Females due to latex, and post-operative perioperative due to exposure to muscle relaxants and idiopathic. Clinical features are mainly due to the inflammatory mediators, which usually manifests in four main systems: skin, gastrointestinal, respiratory, and cardiovascular. Skin, we all know H1 receptors due to release of histamine, and we normally experience pruritus, urticaria, angioedema. Angioedema usually resolves within 24 hours. Warmth, flushing, and erythema. Respiratory symptoms mainly include, due to bronchoconstriction, there will be dyspnea, wheezing, chest tightness. Upper respiratory symptoms may also occur: nasal congestion, sneezing, rhinorrhea. Laryngeal edema, most serious complication, due to which patient can land up in dyspnea and ultimately cardiac arrest. Often benign with a sensation of lump in the throat, may progress to dysphonia, hoarseness, drooling due to inability to swallow secretions, stridor, asphyxia. Gastrointestinal symptoms due to H2 receptors: abdominal cramping, nausea, vomiting, diarrhea. Cardiovascular, mainly due to vasodilation, there will be hypotension and reflex tachycardia. Symptoms include lightheadedness, tachycardia. Bradycardia may occur in later stages. Hypotension, vascular collapse. Signs includes arrhythmias such as premature atrial contractions, atrial fibrillation, bundle branch blocks, peaked P waves and right axis deviation, ventricular premature contractions, ventricular fibrillation, asystole, and myocardial infarction. 80 to 90% of the anaphylactic episodes are uniphasic. Around 10, in some cases, for about 10 to 20% of the cases, they are biphasic, which means anaphylactic symptoms returns about an hour or longer after the resolution of initial symptoms. Anaphylactic reactions are particularly dangerous when hypotension or hypoxia occurs, leading potentially to cardiovascular collapse or respiratory failure, anaphylactic shock with hypotension, and death. Common drugs causing anaphylactoid reaction. Anaphylactoid reaction is non-immune mediated. There is no role of IgE in anaphylactoid reactions. Anaphylactoid reaction are in which the trigger directly stimulates release of inflammatory mediators. Like NSAIDs include aspirin and radiocontrast media, vancomycin, and protamine sulfate, which we use in heparin over dosage. Anaphylactoid reactions also occurs due to exposure to in dialysis patients who are allergic to some chemicals which are used in the sterilization of dialyzers, like bioincompatible cellulosic containing membranes. Part of dialyzer, if they are incompatible to this, they can patients may develop anaphylactoid reactions. Dialyzer reactions can be divided into two types. Type A is IgE mediated hypersensitivity reaction, It is due to ethylene oxide. Ethylene oxide is normally used in the sterilization of dialyzers. When patient is incompatible to ethylene oxide, he can produce anaphylactoid reaction, which is type B reaction. Is it is a complex reaction and non-specific, includes chest and back pain, which typically occurs several minutes after exposure to dialysis and resolves over a period of continuous dialysis. Allergic reactions to contrast agents. Contrast agents also causes anaphylactoid reactions, which we normally use in radiology. Patients with history of significant contrast allergy should be pre-medicated for at least 24 hours prior to the planned coronary angiography with corticosteroids and antihistamines. Non-ionic low osmolar contrast agents have lower reported rate. Trimethoprim sulfamethoxazole can also cause anaphylactoid reaction. Human tetanus immunoglobulins and some penicillins and muscle relaxants can also cause anaphylactoid reaction. Paclitaxel, which is a chemotherapeutic agent, can also cause anaphylactic reaction because it usually requires polyethoxylated castor oil. Patient can develop anaphylactoid reaction to castor oil, which is a part of paclitaxel. IgE-mediated anaphylaxis. Antibiotics like penicillin, cephalosporin, sulfamethoxazole, proteins like venoms, heterologous sera, latex seminal fluid, hormones like ACTH, insulin PTH, gonadotropin releasing hormone, chymopapin, streptokinase enzymes, and foods like peanuts. Most of the patients usually have allergic reactions to peanuts in such cases, and soya also. Therapeutics like allergen extracts, vaccines mostly live vaccines, intraoperative agents, thiopental, muscle relaxants, protamine, fentanyl. Chemotherapeutic agents, as we already discussed, like paclitaxel. Local anesthetic agents. Corticosteroids can also cause anaphylactoid reaction, but it is very rare. NSAIDs causes anaphylactoid reactions. There is also a triad like Samter's triad, in which patients develops bronchial asthma due to intake of aspirin, which is an NSAID. Differential diagnosis includes vasodepressor reactions, flush syndromes like carcinoids, due to lung carcinoids or intestinal, restaurant syndromes like scromboidosis, because scromboidosis usually occurs due to intake of fishes containing high levels of histamine. Excess endogenous production of histamine, like in cases of mastocytosis. Non-organic diseases like panic disorders, vocal disorders, undifferentiated somatoform anaphylaxis, chronic idiopathic urticaria and angioedema. Tryptase is usually diagnosed in serum. In comparison to histamine and MIAA, its half-life is high, so we can use as a diagnostic tool. 9-alpha 11-beta PGF, prostaglandin F2 can also use it in the diagnosis of anaphylaxis. It is usually diagnosed in urine. Serum tryptase, which peaks 60 to 90 minutes after the onset of anaphylaxis, can be measured as long as 5 hours, can be measured up to 24 hours. Ideally within 5 hours, up to 5 hours we can measure serum tryptase. Like in histamine, it expires in less than 1 hour after the onset of anaphylaxis, so by the time we send samples, it is already late. Treatment of choice is intramuscular administration of epinephrine, 0.3 to 0.5 ml. Normally it occurs in ampules of 1 ml, with repeated doses at 5 to 20 minutes interval as needed for severe reaction. That means until the relief of symptoms like bronchoconstriction, hypotension, we have trachea flushing, we can repeat epinephrine administration after at a regular intervals of 5 to 20 minutes. Patients who suffer from anaphylaxis to be placed in supine position, because there will be hypotension, and if the patient is in standing position, it will aggravate the situation. IV fluids and vasopressor agents may be administered in the acute medical setting if intractable hypotension occurs. To overcome hypotension, we normally use IV fluids and vasopressor agents. Oxygen, if there is a bronchoconstriction, we can try for oxygen. If in spite of giving oxygen, if patient is not improving clinically, we can go for endotracheal intubation or tracheostomy. Antihistamines, glucocorticoids and bronchodilators can also be used, but treatment of choice is to epinephrine. Acute treatment of anaphylaxis, early recognition and treatment. Whenever when we give some drug, we have to see whether patient developing features like hypotension, trachea flushing, bronchoconstriction. If we suspect, early recognition plays a key role in anaphylaxis. Assessing the nature and severity of the reaction. Brief history. History plays a major role, rather than even though there are diagnostic tools like kinase and MIAA and histamine, but history plays a major role in these situations. General therapy includes supplemental oxygen, intravenous fluids, vital signs, and cardiac monitoring. Goals of therapy are ABC. Usual first line to airway, breathing, circulation, we have to give preference. Prevention is better than rather than exposing a patient to anaphylaxis. Avoidance, if a patient is previously gives history to certain drugs, then we have to avoid such kind of drugs in such patients. Tolerance induction, desensitizing, all means the same. They are like repeated exposure to mild doses of such agents, and we have to see that patient developing a tolerance to some to that agents, as we also use in panic disorders and for example in all allergic reactions, progressive desensitization is usual. Thank you.